Okay, so we're live. Hello, everyone. Hello, everyone. My name is Mr. Azim. I'm the staff director for this term, and I very warmly welcome you all to the Universal Health Webinar. We have a great lineup of speakers for you guys. And what we're going to be doing in this Universal Healthcare webinar is discussing universal healthcare from a variety of ways and different aspects. So I'm going to give the floor to different speakers to introduce themselves, their names, where they're from, and what is their specific field of interest in universal healthcare. Mara, do you want to start?
Yeah, that's okay. So hello, I'm talking from Brazil. My name is Mara Foss. I'm a young doctor that works in a rural area here in Brazil. And I'm also one of the creators of the Rural Cities Group that is under the umbrella of the WONCA, which is the World Organization of Family Doctors. And I'm quite enthusiastic about family medicine and primary care. And I do think this webinar, and when we talk about universal health coverage, we need to discuss about rural areas, which are half of the world almost, and which just 20% to 20-something% of doctors decide to work in these areas. So if you really want to talk about universal health coverage, we need to talk about family medicine, primary care, and rural. That's all. I think you're muted, Misha.
Thank you. Thank you very much. Dominic, do you want to go next?
Yeah. Hello, everyone. My name is Dominique Verwoerd. I'm a final year medical student at the Catholic University of Leuven in Belgium. And I'm also chair of Incision, the International Student Surgical Network. Incision is the largest student-run network in global surgery, and global surgery, which is the field I'm going to talk about today, is a field within global health that tries to achieve access to safe surgery and anesthesia for all.
Thank you very much. Batul, do you want to go next?
Hello, everyone. I'm Batul Wahdani, IFMSA Vice President for External Affairs. I come from Jordan. I'm here today to talk to you about universal health coverage from an external point of view. Universal health coverage is one of our global priorities, one of the global external focus areas this year. And we will be updating you about our efforts on an external level and to speak to you about the health workforce aspect in universal health coverage. Thank you.
Thank you very much. Christina?
Thank you, Nishfa. Hi, I'm Christina. I'm the program coordinator on health systems for this term, and I'm from Greece. I'm here to talk to you about the handout and the follow-up process of this Universal Healthcare Day campaign, and also about the program on universal health coverage.
Thank you very much. And as I've introduced myself already, my name is Ishwa. I'm the SCOF director for this term at IFMSA. And just a little bit about SCOF and universal healthcare. So universal healthcare is very evidently a global public health issue, and IFMSA's priority for all regions, not only in the GFAS, which is a global external focus areas, but also within the NMOs. We see a lot of NMOs and a lot of work which is going on in the form of projects nationally and regionally, in the form of activities. So for SCOF specifically this year, universal healthcare has been a priority. It has been adopted as a priority, not only around the Universal Healthcare Day, which was on 12 December, but also generally for throughout the year. We were fortunate enough to secure a universal healthcare grant by the UHC Coalition, and thus we will be working on universal healthcare sessions throughout all the regional meetings, which would be in the 5 regional meetings, and in the 2 General Assemblies, which is the March meeting and the August meeting. We also had a universal healthcare campaign recently, and the follow-up of which we're going to be talking about with Christina at the end of this webinar. So I'm going to start with Mara, in which we can talk about primary healthcare and rural healthcare. I would have a few questions for you, and if we could go in that way.
Perfect. Move on.
Okay, so my first question would be, what is primary health coverage and rural health, and how is it relevant to universal healthcare?
That's a good question. If we estimate we have an estimation from the WHO and from the World Bank that in 2030 we will need around 40 million health professions, new health professionals, but they will concentrate in the developed areas, in the developed countries, and the low and middle income countries we predict a shortage of 18 million health workers. And where this concentrate more, 7% of the world that lives in rural areas are the poorest. The need will be bigger in the rural areas. So as we predict a shortage for poor countries, and we predicted that, and the poor countries are mainly rural, we need to think about rural health and reflect about covering these areas, which is lack of access. The main problem is lack of access. The range of disease are bigger. Usually we are hospitalocentric and concentrated just to work close to hospitals, close to technology, but people were still dying of simple things, and we are not reaching them, and we are not empowering the people from the same to care of their own population. So, and primary care is basically the basis of the all good health systems that we have in the world. And the family doctors or the general practitioners, which were people that work in primary care, are like they do the filter of all that will enter, and then they do the coordination of the care. And we are more usually near of people. So even myself, when with my people, I'm the place where I work is close of the area of the patient. So I work in a rural area. So if we want to have universal health coverage, rural need to be in the top list, and primary care, which is the base of a good health system, need to be together on the top list of things. So I think this is why it's relevant.
So when we talk about primary health coverage and universal healthcare, what would you say is the problem statement right now? What are we lacking in primary healthcare in respect to universal health coverage?
One of the things when we talk like with IFMSA is that people usually never heard about primary care in some places, and some people never heard about what is a general practice or what is family medicine. And also we need to create a more prepared formation for students. This is one of the first things to get more people more enthusiastic about it, and we need to have more money also go into these rural areas and getting prepared. And maybe all health systems should be grounded and constructed based on a primary care, which will will filter all the diseases and people, and will be working with more close of the communities.
Perfect. I can definitely agree on the fact that there are definitely countries where students have not really heard of family medicine or even primary healthcare to that extent. So my next question would be, how are organizations and other stakeholders working towards universal healthcare for primary health coverage or rural health, or if you even want to talk about your organization a bit?
First thing is to think about it, like when you get aware, is to see where the things come. When you eat carrot or potato or any kind of food, usually is produced in a rural area. And when you got in your hand an apple, you can think where this apple came from. is the person that created this apple and make it came to my hand have back pain because carried a lot of weight? Does this person have pesticide intoxication? Does this person have quality health care near of him or her that can rely on, and that's free, that's for all, that's our human rights? So we are surrounded, even if we live in a big city and if we study in a big city, we are surrounded by rural, and usually it is ignored. So the first thing is to get aware. And so in 2016, end of 2015, we created the Rural Seats, which is a kind of an acronym from World Rural Health Doctors in Training. And we started with the Rural Family Medicine Cafe, which Nisha have participated already, and which is an informal way to discuss with people from all around the world about dams in rural, and we mix experienced general practitioners and family doctors and with medical students and young doctors, and we get together to think about rural. So this is one of our initiatives, and the blog of the Rural Health Success Stories, which any student can write and bring your opinion and your experience about rural. When we think about narrative-based medicine, not opposed to evidence-based medicine, but when we think about the histories of people, because the diseases are quite similar. We have parameters and things to like follow. However, what is different from one disease to another is the person. So if we can think differently and share these narratives, it's quite different care a patient with heart insufficiency in a rural area and compare it to a place that we have all the things and that you have support and you have an ambulance near. Usually if I need to transfer a patient, it took hours to get an ambulance. And then I need to be more, I need to have more skills to taking care locally, or I need to know how to identify agrotoxin intoxication. So it's quite different. So if we need to get aware, and then we need to discuss it, and then we need to empower people to do the work locally in the better way instead of doing the work for them. So this is one of the, I think, for myself, this is one of the most important things. And then on Rural Seeds, we created a mentor-mentee program, which we are connecting like a student from any part of the world or a young doctor with an experienced rural doctor from any part of the world. We are running our pilot. It has a lot of things to make it better, but we already have good results and people that are getting more aware of rural. So I think this is one of the things of Rural Seeds and under the Wonka Rural Working Party.
Thank you very much. So I'd like to ask you if you have, if any experience or any story you want to share regarding this. I know you have many. And just a bit even on the notes of narrative medicine and just more of a touch towards it.
Yeah, okay. Yeah, I do have many. Some of them I lived as a student. So I will try to bring one of my student stories on rural health. One of them, I was with a doctor in the rural area, and then a guy very bad arrived, and we need to do the resuscitation on him. And then we said, please call the ambulance. And then they said, but there is no phone, there is no telephone. And then another guy with like a horse, need to run to a place where to reach a telephone, to call an ambulance, to come to and then the ambulance didn't know how to reach ourselves. So it's much more hard to be a rural GP in some ways than to be comfortable and near of all the facilities. But the most, I think the stories that I like most is, I will try to make it shorter, but it's about empowerment and rural communities, actually a fishing community. And we started to work with women in a fishing community when I was a student, when I was like hating the medical course and I wouldn't like to be a doctor anymore. I was just in my first year. And then we started to think together, myself and a colleague, why we were doing medicine. Because we feel that we were not effective and that we were like just doing things and people were not doing what we would think that they were supposed to be. And then we stopped to question ourselves if we were doing it in the right way. We came from a biomedical point of view and we were in first year, so anatomy and all the things that break the human body in parts. And then we start to think and reflect. And then we created a project called the Health Education League. And we started to go to the community and ask for people, what is health for you? And they were like so complex and have their own views of what is health. And then we started to construct things together. And then we came up with a project in this fishing community. And the women decided to fight for their right to health. So we empowered them with the Brazilian law, which says that health it's a right for all. And then they weren't aware, and then they didn't have a general practitioner and even a health-based care near them. And then the women organized themselves and fight and struggled for their right to health. And now they have health coverage on the whole community. So it's not my story at all, but it's their history that I always like to share. And it's about empowerment and it's about rural areas and how it's important to engage and think differently.
So my last question would be that from the experience that you have and the knowledge that you have, what would you say, how can medical students strive and promote primary healthcare or rural health as a part of UHC?
Well, it's in our hands, in the hands of the medical students. I think one of the things is get exposure to rural health, is to think about the apple that you hold in your hand. When you eat something that came from rural, you are like interacting with rural people, but you usually forget because we get it on the supermarket and it's easy breezy. And it's on the day by day. And if your universe don't talk about primary health care or don't talk about family medicine, try to go and check and search about it. And you can engage on rural seeds or you can engage on Wonka and the young doctors movements. You're all welcome. And also, I think that as much you bring to discussion, as much we can deeply think about it and construct policies about it and reflect about rural and reflect about half of the world that is not covered. So I think it's on the day by day. I don't think that we are a revolution. We think any of you can participate on the Twitter chats or even on the video call of the Rural Family Medicine Cafe. So just search about it and discuss and have conversation, and it will be awesome to have you on board. So all welcome. And we have the India conference of rural health that will be in April of next year. The abstract submission will be until the end of this month, and it will be a good opportunity to get together and discuss rural health. So if any of you all of you are welcome, and if you get interested, you can email myself and we can keep talking about it.
Thank you very much, Maya. So we're going to move on to the next segment, which is global surgery and universal healthcare. And this is Dominique. So I'm going to ask, and it's very similar, where I'm just going to ask you a couple of questions. And, we can go about it this way. So I'm just going to start with, what is global surgery and how would you say it is relevant to universal healthcare? Coverage?
So as mentioned at the start, global surgery is the field within global health that tries to achieve access to safe surgery and anesthesia care for everyone, everywhere. At the moment, worldwide, 5 billion people, which means 5 out of 7 people in the world, do not have access to safe surgical care or anesthesia care when needed. Now, when we look at what access to safe surgical care means, we see there are 4 points that we need to address. First of all, there's physical accessibility. How close is the nearest facility providing essential surgical care? Is there a facility nearby that provides just the basic care, or do we need to travel 2 hours to reach a hospital? Is the road infrastructure decent enough? Is there any ambulatory services? Do we have to walk to the nearest facility, or is there public transport available, etc., etc.? Now, a second point, even when there is a hospital nearby, is the concept of capacity. And there, on the one hand, we have infrastructure, again, hospitals, operating theaters, pre- and post-operative care, etc., etc., but also human resources for health, especially surgical specialist workforce on the one hand. It is estimated that by 2030, at least 1.3 million, and more precise estimates suggest 2.28 million additional surgeons, anesthesiologists, and obstetricians are needed. But also beyond surgical specialist workforce, there is the need for nurses, there's the need for technicians, there is the need for pre- and post-operative care, and all the human resources that are accompanied with it. Then a third point, even if we have a hospital, even if we have the human resource for health accessible in that hospital, we still have to think about the quality of care. There is no point of having access to surgery when the specialists aren't trained enough, when there is no decent control of hygiene, of sterility, when there are high rates of surgical site infections, when there are high rates of complications, etc., etc. So quality is also a very crucial point. And a fourth point, and this links to the very strict definition of universal health coverage being the financial aspect, is affordability, of course. Globally, about 3.7 billion people are at risk for catastrophic expenditure when they need to access surgery. Of these, 81 million people already get pushed further into poverty, meaning below the poverty line of $2 per day every year, because they have to pay for surgery mainly out of their own pockets. So these are the 4 concepts that we need to think about when talking about the 5 billion people that do not have access to safe surgical anesthesia care. Now, as a result, because of those high numbers of inaccess to surgical care, every year at least 17 million people die due to preventable conditions that could be treated or could be mediated with access to surgery. Now, 17 million people every year, that means at least 4 times the mortality rate of HIV, malaria, and tuberculosis combined. Besides this high mortality rate, there's also a high morbidity rate, with about 28 to 32% of the global burden of disease, meaning 1/3 of the global burden of disease being attributed to conditions that could be treated or mediated with surgery. These range from complications during pregnancy, such as, for example, obstetric fistulas, congenital malformations, such as clubfoot, injuries, which are responsible also for 5.8 million deaths every year, a lot of non-communicable diseases, especially cardiovascular diseases, malignancies, etc., etc. So both mortality and morbidity is very high. And this, in the whole scheme, also looking beyond mere financial aspect, but also the quality aspect, having access to not just surgical care, but care in general, means that surgery and anesthesia care are essential components of universal health care. And if we want to achieve health for all, we have to address safe surgery and anesthesia as well as a component of it, because otherwise we don't have health for all, but only partial health for some.
Thank you very much. My second question would be something we have already talked about, but what would you say is the problem statement in the status quo regarding global surgery?
I think the biggest issue at the moment is dual. On the one hand is, of course, the recognition of surgery and anesthesia on an international level. A big myth that is surrounding the attention of it internationally, and it has been addressed in the past couple of years, but still, is the fact that a lot of people still think that surgery and anesthesia care are too expensive to scale up in a country, or too complex to focus on within a country, within rural areas, within LMICs, etc. However, in 2014, if we look at the cost-effective picture, in 2014, Karis, Grimes et al., they show that actually surgery is a very cost-effective procedure, especially if we look at essential surgical care, in terms of C-sections, in terms of injury facility, etc. And is actually more cost-effective in several global health priorities, such as, for example, oral rehydration therapy for diarrhea, such as antiretrovirals for HIV, etc., etc. Now, on the other hand, also in terms of global funding, surgery and anesthesia systems are very cost-effective to invest in, as there is only, and I say only within brackets, there is only $350 billion that is needed to prevent the loss of $12.3 trillion in terms of loss of economic growth by LMICs by 2030. An investment of only $350 billion is nothing compared to the $12.3 trillion. However, surgery does not get the attention on the one hand on an international level. For example, at the WHO, there's only one person working on surgery, even though there are 17 million people dying every year due to lack of access to it. Whereas, for example, and I'm not saying that we have to take people away from that department, for example, polio, which has recently been, apart from some outbreaks, has been acknowledged to be eradicated. There are still 50 people working on polio within the WHO. So this is also, again, a sort of imbalance that underlies the lack of attention for it. On the other hand, there's also no funding going towards surgery, not just the recognition, but also no funding going towards it. Which brings me from the one point, the recognition, to the other point, and that is the fact of the lack of funding or a lack of global fund for surgery and anesthesia care.
Thank you. My next question would be, how are organizations or other stakeholders working and striving for global surgery in UHC and even your own organization?
Yeah, so global surgery in itself is a very young field in the sense that recognition, and especially on an international level, has only been there since a couple of years. When we look at 2 years ago, 2015 was a pivotal year for global surgery. And that was because of two reasons. On the one hand, there was the Lancet Commission on Global Surgery, which is a commission by experts in global surgery from around the world, that was created 2 years before. They brought out the report Global Surgery 2030, and they mapped the state of access to surgical care in 2015 globally. So all the big numbers I mentioned in after the first question are addressed in their report as well. But they showed how the state was globally, what need to be done, what can be done, and how we need to monitor everything that comes after. Now, on the other hand, the 68th World Health Assembly in 2015, so the World Health Assembly by the WHO and its member states, etc., they acknowledged safe surgery and anesthesia as essential components of universal health coverage. When the resolution WHA 68.15, emergency and essential surgical care and anesthesia as essential components of universal health coverage, when it got passed in 2015, meaning that the international community, WHO, its member states, etc., they acknowledge the fact that surgery and anesthesia are essential, that it is something that we need to address, and that is something that countries individually can address as well. Now, around the same time, when we look at incision then, on my background, around the same time, on May 25th, 2015, we started Global Surgery Day. So 3 years ago, this year was the third edition. And every year we have been implementing on May 25th. 2015, 2016 has been mainly social media campaigns. This year, 2017, we had several individual events in our national working groups in several countries around the world, but also had a side event at the World Health Assembly, 70th World Health Assembly this year in Geneva. Now, again, when we look at the 70th World Health Assembly this year, then was the fact that resolution from 2 years ago, 68.15, that needed to be amended this year at the WHA. And again, WHO, the member states, etc., they acknowledged the importance of it. They acknowledge what can be done about it, and they passed again a statement saying that we have to address this topic every 2 years at the WHA. So this means that it is getting more and more attention, more and more recognition is getting is being given to it. And another crucial point this year, another pioneering role, was for Zambia, because Zambia was the first country that brought out their national surgical plan. And that is something that is, at the moment, maybe one of the biggest key factors in how we need to address the current global state. And it is that countries need to acknowledge it on a country level, how they can change it, how they will change it, and integrate it in their national health plans. Now, as mentioned, Zambia was the first country that introduced it as part of their National Health Plan 2017-2021, their National Surgical Obstetric and Anesthesia Plan. And after, several other countries like Tanzania, like Ethiopia, like Papua New Guinea, like Zimbabwe, etc., they are starting as well. They're some of them, like Ethiopia and Tanzania, are in the process of finalizing. So a lot of countries are following suit, and a lot of recognition is gaining, a lot of work is being done on an international level. Now, back again to incision, as mentioned, on May 25th, every year we have Global Surgery Day, which is mainly surrounded around paying attention or spreading awareness to global surgery. We as Incision, we're a platform that tries to unite future global surgeons, anesthesiologists, obstetricians, public health students, public health professionals, etc., around the world to, on the one hand, spread awareness about it through advocating for the cause, education in terms of workshops, whether it's through students, to the general public, on conferences, etc. And the third point is research, which is contributing to the global research aspect, mapping the state, how is it being monitored, how is the process going on, etc., etc.
So do you have any experience or any story that you want to share regarding global surgery?
Yeah, so I'm going to share two stories to show a bit the contrast that is not just a problem for LMICs, but also in developed countries. Mm-hmm. It's not stories from myself that I have experienced, but it's stories that I've recently heard. And the first story is by UN High Commissioner Alan Murabit, and she told this story last week at the UHC Forum in Tokyo. And it was about the fact that when she was 14, she had an appendicitis. Now, she got surgery and everything went well. Her appendix got removed. She was perfectly fine. However, Alan Murabit she's from Canada, but she also has Libyan roots. And a cousin from her, a friend of her, the cousin of a friend, she got appendicitis as well. However, she was not covered by insurance. She was too afraid to pay for the surgery because she didn't have the money to pay for the bills, and she didn't know what would happen if she wasn't able to pay for it after the surgery. And sadly, she passed away because of it. mainly because she didn't have the money for it. She was too scared. There was no health insurance in place. And this is a story that doesn't happen in just an exceptional case. As mentioned, 81 million people are pushed into poverty every year because of it, but a lot of people are also not being pushed in poverty, but are getting high morbidity, getting even, or even passing away because they don't have the money to pay for it and just don't seek treatment. Now, this is one story. Another story, this is about a high-income country, like, for example, the US. In the US, some of you may know about Medicare, etc., but Medicare is not something that is there for all. Medicare costs a lot of money, and a lot of people don't take the step to take it. So they are without general health insurance. They are covered for life-saving interventions, etc., but not for somewhat minor procedures, such as, for example, cataract surgery. Now, in the US, if you need cataract surgery, it costs about, or at least $3,000 per eye to get cataract surgery. Now, $3,000 is a lot of money. Imagine needing cataract surgery at 2 eyes. That's at least $6,000. So in the US, a lot of people, they just prefer, or they do not prefer, but they decide to go blind because they do not have the money to pay for cataract surgery. And cataract surgery is a very quick, very easy procedure, but just costs a lot of money, which a lot of people cannot afford. And sadly, this shows that it's not a problem just in developing countries, but also in developed countries. And again, this is where surgery and anesthesia care link to UHC as well.
Thank you very much. That does definitely give much more perspective to the topic. So my last question would be, from your experience and knowledge, etc., what would you say, how can medical students in IFMSA, excuse me, and worldwide work towards promotion of global surgery to maximize universal healthcare?
Yeah. So first of all, something that students are really powerful in, and you see that a lot within IFMSA, is that students have, on the one hand, a strong network, strong unity. So spreading the word and advocating for a certain cause can easily pass on just your nearest peers at your university, at your local committee, in your country, even at regional meetings, at general assemblies at IFMSA, just spreading the word, and it gets passed on to other cities, to other countries, etc., as well. This you can also expand, of course, to the general public, to your professors at your university, giving them the awareness about how the current state is globally, what can be done, whether it is on a local level, on a national level, an international level, why we need to pay attention to it, debunking the myths, like, for example, surgery being too complex, too inefficient, etc., etc. Beyond just IFMSA, and I'm going to talk, if that's okay, a bit from my own background, is that Incision is a network, an international network, mainly for students who are trying to be involved in global surgery, and in the topics that are covered within it, like UHC, like human resource health, etc., etc. So Incision is an international network which allows you to have international contributions to it as well. Whether it is through, for example, our international team, for which the call is still open for another week if you're interested in it. But also in terms of international research projects in global surgery, in terms of advocating and supporting campaigns such as Global Surgery Day. In terms of education, for example, we had a recent conference in Morocco about global neurosurgery. In May, there will be a conference on global surgery in Belgium as well. So, opportunities. Now, on a national level, we also have 19 national working groups, similar to NMOs, but then mainly specific to global surgery, world regions. If you have a global surgery national working group in your country, I advise you to look for it and get linked to it as well, because it's a good way to get involved on a national level. There's always the possibility of course, with provided support, to start one in your country as well. So these are several ways for students to get involved. And again, The power of students is unity and advocacy, advocating efforts. So I definitely advise you to spread the word and get into it.
Thank you very, very much, Dominique. Now I'm going to give the floor to Batul, and she's going to be talking about health workforce and universal health coverage.
Yes. Thank you, Nishwa. So in IFMSA, since we are the future health workforce and the future medical doctors, we are one of the stakeholders in universal health coverage, and it's very important to be aware of the problem and to work on it from an earlier stage and to advocate on it and to take an active role from the stage we are in right now. And since universal health coverage cannot be solved unless we ensure that the 3 dimensions of universal health coverage are tackled, which are expansion of the population coverage and reduction of out-of-pocket expenditures and catastrophic spending, and ensuring that we are able to respond to the emerging population needs and expectations. And who is going to be doing that? It is the future health workforce who is playing a big role in this. And therefore, the future health workforce and us medical students and health students is one of the main focuses we have in IFMSA when we are tackling the universal health coverage focus area. So when it comes to the health workforce, currently there are being so many discussions related to that, so many problems related to the health workforce in the UHC framework. And one of these problems is the distribution. So not all areas have enough health workers, the enough needed specialties, and distributed to the rural areas and to the main areas within the countries. The other problem is the education and the skills mismatch. Some of what Dominic already mentioned, that currently we are not ensuring that the skills the health workforce are graduating with are enough to ensure the universal health coverage. Maybe we focus a lot on diagnosis and diseases and scientific education, but maybe we should also focus on essential care and primary health care and the needed skills the basic needed skills to ensure universal health coverage in all areas in the countries. And the other problem is that we do not hear about such big topics and big titles such as universal health coverage, health workforce, and ensuring health for all, except in meetings and organizations. And we are very lucky to have organizations which give us awareness about such important topics, but our education system lack these topics, and it is very important to make sure and that our education systems will start tackling such issues from an earlier stage, so that graduates will have the enough knowledge to be aware of the problem from an earlier stage. And finally, the rights of decent work conditions. One of the main problems that the health workforce are facing nowadays is the work conditions. And the decent rights in working conditions and the migration problem. Many health workers graduate from their countries and they migrate to other countries to find better conditions, and resulting in a problem in their original countries as well. So we need to tackle that as well, and we need to make sure that the health workforce is aware of their rights and can address them in an earlier stage. So this is when it comes to the health workforce. And when it comes to our work in IFMSA in health workforce, we started working on the health workforce last year, and it was one of the global external focus areas for us last year. If you remember, IFMSA members, we had a theme event in August meeting, which was about human resources for health, and IFMSA developed a plan of action, which is a human resources for health plan of action within the SDG 3 framework, which tackled 4 important pillars, which is international advocacy, national advocacy, capacity building, and gender empowerment in the health workforce. And we are currently in the stage of implementing this working plan, and we are developing a policy document on the global health workforce, which is going to be proposed in March meeting.
Thank you very much, Batul. And we additionally have IFMSA at a global level universal health coverage.
Yes. So when it comes to external representation and universal health coverage, IFMSA has been one of the important stakeholders in the global discussions and the decision-making processes that are happening everywhere. And starting from the beginning of this year, well, starting from previous years, but what we did as well this year is that we included universal health coverage as one of the global external focus areas for IFMSA, which are the main priorities which we focus on in our external representation and efforts and meetings. We recently joined Universal Health Coverage 2030, UHC 2030, which is a very important platform and a multi-stakeholder platform which promotes collaborative working in countries and globally on health systems strengthening and encourages knowledge sharing and facilitate accountability. It includes governments, civil society members, and NGOs, and IFMSA represents youth in this important platform. And we have recently joined it, and we are taking a very active part in it. When it comes to external meetings, we participated in the United Nations General Assembly in September, and we spoke about universal health coverage in one of the high-level sessions that was held in UNGA and in New York. We also participated with UHC 2030 in a side event about it and expressed the hopes of the younger generation and what they see by universal health coverage by 2030. During this term as well, since one of our main areas to focus on is the human resources for health and the health workforce, we participated in the 4th Global Forum of Human Resources for Health in Dublin in Ireland. And not just only a participation, we organized HRH Youth Forum, which was a full day of capacity building sessions, knowledge sharing, and active discussions between youth from different health professions, pharmacy, nursing, midwives, medical students, economics, and public health, and many other professions, in which they discussed the importance of strengthening the health workforce and what issues they are facing. And then after this forum, there will be a youth hub, which is going to be launched, and IFMSA will be taking part in it in order to represent the youth agenda within the HRH agenda. And recently we participated in the UHC Forum 2017 in Tokyo in Japan. And in the forum, we were able to share our commitment, the commitment of the younger generation and youth from all over the world in front of government, civil society members, NGOs, and many important stakeholders towards empowering youth to be active advocates and capable of implementing UHC in their communities. We also participated in a side event there and spoke about the issues that youth face, not just only as a player in the UHC agenda, but also to focus on youth health and adolescents' health in universal health coverage when we tackle this important issue. And one of the things that we also worked on is a commentary report with the International Youth Alliance of Family Planning, both being members of the Partnership of Maternal, Newborn and Child Health, PMNCH. We developed a commentary report on the UHC Global Monitoring Report 2017, in which we expressed what we saw lacking or very strong in this global monitoring report that was released in UHC Forum 2017. And one of the things that we highlighted in this commentary report is that stigma, inequality, and discrimination are barriers to achieve UHC, and therefore national level human rights laws should be tackled in order to ensure essential services are being available and accessible to everyone. We also address the importance of having youth and adolescents friendly services in every country and in all areas, and shed light on the importance of youth and adolescents' health in UHC. And when it comes to future opportunities and things that we are working on right now, we will be participating in WHO EB meeting, of course, and we will be speaking about universal health coverage in the sessions that are related for that. We also have a very nice event, and you all know about it, hopefully, which is the pre-WHA, in which we do an excessive capacity building workshops that tackles important health issues. And one of the streams we are having is about universal health coverage we will be running a 3-day workshop that focuses on universal health coverage in terms of capacity building and knowledge. And finally, one of the things that you may not know about is one of the theme topics that will be tackled in March meeting 2018 is universal health coverage in addition to global epidemics and hepatitis C. And we will be speaking to our members about universal health coverage, and we will be having very cool speakers that we will tell you about later. So it would be really great if you are attending the March meeting to attend the sessions of the theme event and to participate in it. And finally, I would like to remind you about our policy document about universal health coverage, which we are running a review for it right now because of the great involvements that we are having in different platforms right now. And we saw the importance of changing it and reviewing the policy documents we have, so it will be capable to cover the different areas and the different working areas we are having. So we are calling for policy commissions and for volunteers to work on developing this policy and reviewing these policy documents. So if you are able to join, please join us and let us know what you think about universal health coverage and what IFMSA should focus on.
Thank you very much, Batul. I'm going to move on to Christina. Hello, Christina. So, Christina, you would like to talk a little bit about what would be the follow-up of the, firstly, what was the universal health coverage campaign we have, and what would be the follow-up of that campaign?
So this year, as you already know, for the Universal Health Coverage Day, we started a campaign based on the past, the present, and the future of universal health care. So we are at the moment at the present, and we are going to see some stuff coming up in the following days about the present and also about the future of universal health coverage. So in the following days after the campaign ends, you will all get the handout of the campaign containing also sources, information, everything that you can check on universal health care. On the Universal Health Care Day part, that's mostly it. And the material is going to be renewed at about every 2 months. So more information on the topic will be added to that.
Thank you. And do you maybe want to talk about a little bit about the programs?
Of course. So as you know, the program is health systems, and one of its focus areas is universal health coverage. Other focus areas are rural health, global surgery, access to essential medicines, and everything else that is health systems related. So if you have any activities that are based on this health structure of your health system, or you giving access to more people to have health care, or having campaigns, webinars, whatever, everything related mostly to health systems and especially universal health coverage, please feel free to fill out the enrollment form, with which we have been spamming you for the last 1 week. And we will continue doing so, or feel free to contact me and ask me questions about the process, the enrollment, and your benefits, what will you gain from enrolling, and stuff like that.
Thank you very much, Christina. So in the last section, I'm going to move towards questions. So if any of the people who are viewing have any questions, please leave them in the chat box on YouTube. And until then, I'm going to take some questions that I already have. So for Mer, I have a question which says that what is the difference between effective primary healthcare coverage? Because most of the countries, like my country, already has an infrastructure for rural health?
Sorry, can you repeat?
So basically, the question is that how can you define what is an effective primary health coverage structure? Because most of the countries do have infrastructure for primary health coverage. So when can you say that there's a system which is effective?
I do not know exactly this data. However, we know that when we cover like a rural GP, can cover like 90% of all problems of the people that reach. So if we are well prepared and if we cover all these disease and this care, we probably are being effective. But for being effective, we need to have access for all. We need to have a primary health coverage that reach all places, that people are, that's near people, that they don't need, that can reach walking mainly, that we can have a primary care which is accessible, which is not where people do not need to pay, as it's a human right, a basic human right. Health is a basic human right. So this is a effective primary care that's not paid, that's accessible, that have the door open, that cover the main necessities of each community, which is different from another. And in rural areas, mainly that's near people and it's accessible. I do think this is one of the keys for having a efficient rural healthcare. What we suffer in rural areas is that we have a shortage of people that is interested in working with primary care, because usually people will be isolated, working in a rural community. The rural community will be the same community that you raise your son, that you have your family. So this make an issue for people usually people learn to be more far from the patients, but usually patients from the community will be part of your community and where you live. So this is sometimes quite hard. So we have a pipeline that makes more difficult that people get interested in reaching rural areas. However, we need to have the consciousness that rural areas are a great part of world, and we need to find ways to tackle these shortages and to make it available for all.
Thank you very much.
Thanks, that.
Thank you very much. My next question is from Hatem, who says that when we talk about universal health coverage, are we only talking about first aid, or are we talking about the whole spectrum? So Mayara, Dominique, whoever would like to answer.
When you talk about
universal health coverage, are we only talking about first aid?
No. When you talk about universal health coverage, we are talking about a basic human right, that is the right to health, and it's a universal right to health, which means that it's for all kinds of problems, and mainly it's for the whole health of the person. So the universal health care is not just about first aid. It's about aid of chronic disease. It's about accidents. It's about taking care of child, elderly people. When you are a family doctor, you take care of the whole family. So when you talk about family medicine, we are talking about caring people since before they born. We are prepared to care of pregnant women, young people, children. We can do, depending which part of the world we have people that perform surgeries and that do the generalist pathway and then specialize on surgery. So we have loads of paths, and it's covered for all in our ages and in any issue that you have in your health. and promoting health as well. So it's not just about first aid. First aid is just a little bit of all of it.
Thank you. Dominic, would you like to comment?
Yeah, I would like to add something as well. I would agree with the fact that it's not just first aid. Of course, first aid is by and large maybe the most important part of it. But a lot of conditions, as Myra told, are beyond the spectrum of just mere first aid. For example, congenital malformations such as club foot can prevent someone to lead a normal life, can prevent them to contribute to their community, to their country's economic growth indirectly, etc., etc. So a lot of life changing procedures also are part of universal health coverage. Another example is, for example, and again, I go back to my background in global surgery, for example, complications after lack of access to safe obstetric care, complications such as obstetric fistulas. In some communities, people who do not have access to care for obstetric fistulas, they are being exposed out of their community merely because of the stigma being present. And this, again, has social implications. This has personal implications. This has financial implications because that person cannot contribute to their community, cannot contribute to income of the family itself, etc. So, in conclusion, I would also agree with the fact that it's and not merely first aid, but also everything that comes with it beyond just that.
Thank you. The next question I have is for Dominique. That you just talked about how there is an image which is attached to global surgery that is too complicated. So it mostly defers people from going into it and thinking that it can be as accessible as other medical services. How do you think that we as medical students can tackle this problem, or even promote this image of surgery as something which can achieve coverage?
So sorry. So how can we as students make sure that the perception of complex is addressed? Or?
Exactly. So how can we, as medical students, try to break the perception of global surgery as something which cannot be achieved in universal coverage?
So first of all, with the report from 2015, Global Surgery 2030, with all the data that is present, that's one thing that we have the evidence. We have the data that shows why we need to address it, how we can address it, and what happens when we address it. And the fact that it is cost effective, the fact that it is possible, that it is achievable for every country in the world, whether it is mainly through domestic resources or supported, albeit just to a small extent, by external support. But the fact that we need to not think that it is not possible, because it is possible, the data is there. And of course, we need to accept the fact that surgery will always be complex, but it will never be too complex. Surgery will always need anesthesia care, will always need sterility, will always need the equipment and proper trained workforce. However, there are a lot of ways that can mediate the different barriers that are there. For example, in terms of human resource for health, a lot of developing countries are implementing the concept of task shifting, which is training lower skilled health workers to perform certain procedures, such as, for example, nurses being trained to perform C-section, procedures such as evacuations of hematomas, of small suturing, etc., etc. Another thing is that a lot of developing countries are implementing cost-effective ways of performing surgery. For example, in India, they have started implementing a very cheap cataract surgery, which only costs, if I remember correctly, $15 per procedure. And if you were here at the start or earlier in the webinar, in the US, it costs at least $3,000 per eye for cataract surgery. So again, it also shows that it doesn't have to be too complex. Ways. And then also beyond just that, beyond just procedures, several developing countries have also been preparing very creative in terms of equipment. For example, we don't need a $10,000 drill just to perform an hematoma evacuation. Several countries have been using just regular drills that we use at home with a sterilized cover. So these are just some examples that goes to show that it is not too complex, that it doesn't have to be too complex. And when we look at students, how we can show the world that it is not too complex, we have to show what is already present there, and we have to make sure that people are getting, or that the awareness is being spread, that people are being aware.
Thank you very much. I have another question from Tiva, and I quite like this question. So she wants to ask that, what kind of activities do medical students do locally, apart from promotion? So in universal healthcare coverage, we see a lot of medical students promoting universal healthcare, but what other activities can we do on the ground? So if anyone would like to answer. Mayara?
Yes. Well, there is a very known phrase that is think globally and act locally. So for changing the world, it's not about like, you need to think locally. So you need to identify locally who is your rural community. You need to identify who is in, if someone is not accessing like a surgery, as Dominique is saying, you need to identify what's going on around you. And then from them, you can work directly on the ground and need to be really respectful. And this is one of the things that we do not reach a community thinking that we know all about them, because usually we don't. Even if you have some data isn't people. So we need to listen them, understand the needs, and then from these needs, we need to think together with them, which will be the best answers. And then from that, we can fight together, and not just fight as medical students, but struggle together to reach health coverage for all. And then it will be mainly in place, a lot of places. It will be politically, it will be working on the day by day. It will be with your patient on the day by day. So all of it involves. So be like, the first thing is think about what you're doing, think about where the things that you use come, and think about the people that is on the back, and maybe try locally to find them and check how is the access and research it, but mainly heard people and think with people what is the best way for anything.
Thank you very much. I would definitely like to add something here, that whenever we're talking about universal health coverage and working on the ground, not only promoting it, the first thing that I can also say is something similar to what Mayara said: recognize your target group. You need to see what, number one, how is universal health coverage in your country? How many people are getting covered? How many people are not getting covered? What does that coverage entail? It does not necessarily mean that just because they are covered means that they're covered for all the essentials, or for an enough quality of health. Once we have realized that, then there are very large groups of people that you would realize in your country are either not covered. So for instance, in my country, this is also answering another question about what IFMSA does on the ground level. As an NPO, there's a project sort that we did, which was again on rural health, because the first step is identifying what people or what target group is not being covered by universal health care or is not being covered, and then again is that you can start from there. And you can start from how you can go about it. It could be that those people need surgery more, those people need a specific type more. But that is how basically you start with targeting realizing your target group and then working with them, essentially. Would anyone else like to comment on this?
Yeah, I would like to comment first of all on what you said, but also the original question was what students can do beyond mere advocacy, right?
Mm-hmm.
To increase coverage, basically.
Mm-hmm. Mm-hmm.
Well, first of all, also to chime in on what Batul said, students are the future health workers are the health workers of the future. So we play a crucial role in, first of all, how our own training is taking place, but also the ones of our peers. So for those who think the medical education at their university is not good enough, could be better, is lacking in some extent, this is something you can also have a voice in and also can help and make it change. And this is not just an effect for you, but also for the people who are following after you, the future generations. And again, these are future generations of healthcare workers. Another thing is that even as a student, you don't have to just focus on mere advocacy. Advocacy is something we are very strong in, but you don't have to think that, okay, I'm just a student, maybe I'm not fit enough to actually contribute to providing coverage. A lot of NGOs, and you do not have to focus on NGOs, I'm just giving the example of NGOs. A lot of NGOs are providing some extent of coverage, usually free coverage in several countries through missions, through certain health camps, etc. And they often need people to volunteer. They often need students on the ground or from beyond who can contribute to this as well. And this does not have to be from my background in terms of complex surgery. This can also be about vaccinations. This can be about mere health checkups, etc., etc. And then a third point is this somewhat links to advocacy, but also research is something that some students are a bit put away from, but it's something that, especially in these days, is something very important and something that especially policymakers from higher on pay attention to, is whether there is enough basis to found or to provide a foundation for how they are going to write policies, going to implement policies, how they're going to adapt policies. So if you are in a country where, for example, access to surgery is very limited, if you can map how the access in the country currently is, for example, 80% of people do not have access to surgery. Surgery costs this amount of money in our country, but the average income is this, etc., etc. This provides a very strong basis for policymakers in your country and also internationally to see, hey, this is something we need to address. This is something that is not wrong, that is not right, and that can be addressed if we just adapt this in our national health plan. And then also I wanted to address in your point is exactly, we need to see not just whether a certain coverage is present in a country, but also see to what extent is it covered and to what extent is equity there. Because a lot of countries, or for example, the US is a very good example. The US has coverage to some extent, has quality care, has if you take away the affordability factor, has universal coverage. However, the affordability factor is something that limits the coverage. And you can have access to any facilities, you can have quality services, you can have the capacity to do it. When there is not enough financial risk protection or the financial coverage thereof, you pose the biggest barrier of all. And that is, again, to something that Nijwa said, you always have to look beyond merely what is just there, but also to all the other factors.
Thank you very much. Yes, definitely.
About US health system and other health systems that are basically major that in money, and which is one of the things about having health access for all. That is, we need to demonetize health for having it for all in a fair way. Health should be out of the economical interests. But just an example, like if we get a system that it's private and most of people do not access, but we have all facilities, we have the health personnel, that we have the whole, we have everything, it doesn't work for all. This is because of the economical barriers. I usually say that it's kind of you're constructing a bathroom in your house, and then we have beautiful mirrors, and then you have a incredible bath tube, and then you have all of type of lights, and if you have a huge, you have like a place that you can take a wonderful bath and everything, and everything is wonderful, and 10 architects working on that, but on the end of the day, you cannot be, because it's not functional. So we need to think about making things functioning for all as well. And this is about money and where it concentrates as well.
Thank you very much. We had another question, which was asking for resources. For IFMSA, we do have a policies document. Other than that, the resources we definitely have in the Universal Hub UHC Drive, as we heard from Christina, and we're going to have sessions in our BGAs and RMs. In closing, I would like to ask if all of the speakers could say something. Just a giveaway message. Batul, would you like to start?
Yes, I just want to say that, sorry, the camera is not working anymore, but I just want to say that even if we are at the level of the students, there's so much things that we can do, and it is very important to start at the beginning with ourselves and to be committed to improve ourselves in terms of knowledge, skills, and capacity to understand this problem, work for it, and provide all the resources that it needs. In IFMSA, we have so many opportunities to be engaged and so many opportunities to have an influence in internal and external level. We have programs internally, you can do activities and enroll your programs, activities in this program. Externally, you can participate in capacity building opportunities in external meetings and advocacy opportunities. So it is really important to be engaged in this a very important topic, and there are so many opportunities to be engaged, so make sure that you have a voice and you give effort in such an important topic.
Thank you very much, Fadul. Dominique, would you like to go next?
Sorry, my microphone wasn't on. So yeah, I can only agree with the fact that advocate for it, put your voice behind it. Again, to what I've said previously, students are really good at advocating, but really good in having a strong network. So whether you're advocating for global survey, whether you're advocating for universal health coverage or whatever topic, make sure you spread the word. Make sure you tell it to your peers, tell it to your professors, show what is there, what is present, and show what can be done about it. And don't think that, okay, I'm just a student, or maybe you're a first-year student, maybe you're a sixth-year student, maybe your English is not fluent, maybe you're afraid that you're saying something wrong. It doesn't matter. We all have to learn. We all came from the start. Put your voice behind it. Don't be afraid to make any mistakes. You learn by making mistakes. And just know that when you advocate for something, there's always someone who picks it up and spreads it to 2 more people. They will spread it to 2 more people, and eventually it will spread like a wildfire and goes beyond the world. So that's it. And
thank you very much. Christina?
So I would just add that you all have, I know that everybody has wonderful ideas and wonderful projects and activities to implement, and please do, and please enroll them. give yourself the chance to get in touch with other activity coordinators from different countries and talk, exchange ideas, and create something bigger and bigger.
Thank you very much.
Thank you, Nisha. I just want to add to thank you for the opportunity to be talking about rural health, primary health coverage, and talking about these topics that usually people do not stop to discuss. It's very important. And I do think that each of us and who is watching and who will watch later, that we have a collective dream to make health for all. And it's not about our personal dream, but it's a shared dream. So we need to work together, put your hands together, learn with each others, and work together to achieve it. And mainly empowering local people, like each one of us in our country, to work and empower people to reach it. So thank you for the opportunity, and we can do a lot together. And hopefully we will be able to conduct this dream and make it real on our day by day and working together. Thank you.
Thank you very much, Batul. At the ending, in closing, I would like to say something about universal health coverage, that it basically starts from an observation. Just for starting, if you want to get interested, just observe around you, observe the people who are not covered, observe the type of coverage that they have. Observe in your hospitals that if there's a patient who comes in who has a chronic disease, could that disease have been prevented had he had primary health coverage? Does a patient in your hospital comes in with needs a surgery which he can afford? Can he afford it? Is the type of surgery that you have available of standard, of a good quality standard? How many people in your country, even country is a big thing, even in your community, even in your town, are deprived of a right, which is a very basic human right, which is standard healthcare. And from that observation and from that personal experience that you get, that you hear, is which empowers you, which motivates you enough to go out and seek for things, seek for resources. WHO has a lot of resources, IFMSA has a lot of resources. And then from the resources, you empower yourself. We have organizations, we have Rural Seeds, we have Incision, we have IFMSA, who are in one way or the other working, and we are all here to guide you, to mentor you, and even learn from you. And as Mara said, that it is a shared dream, and we're all in it. So I would wish us all to work together to achieve that dream of universal health coverage, and think globally, but definitely act locally, and that is the only way we can achieve universal health coverage. With this, I would like to conclude the webinar. Thank you very, very much, everyone, for being here. Thank you, Mayar, Dominique, Christina, and Batul. It was very informative, and I personally learned a lot. And thank you to the viewers who asked questions and were there. Thank you.